This video lecture is going to finish the chapter on diseases and disorders of the nervous system by talking about pain. Pain is not something we usually discuss much in anatomy and physiology course, but it is something that you as a clinician will be very knowledgeable about and want to know all about it. Pain is basically a subjective interpretation of trauma. Something has damaged tissue and the information travels up to the brain, and the brain tries to take this information and figure out, based upon the different information, what kind of pain and where in the body has occurred. And so that's powerful for you as a clinician to be able to help figure out, what is wrong and is your treatment helping to alleviate that. And so let's take a look at some of this. So what you and I are going to do is we're going to define different types of pain. We're going to talk about different forms, and these can be transmitted through different neural pathways. We're going to talk about how pain is processed both in the short-term and long-term physiology, and then finally assessment. Since pain can be so subjective, we want to be able to find a way to quantify it so that, as I said, clinically, we can tell if we're reducing the pain, if our treatment is helping. Now, for the different types of pain, you can talk about things like cutaneous pain. That's superficial. That's out on the skin. And so someone who's had a burn, chemical exposure, or a rash, um, something along that line, those have very characteristic presentations to the patient. They can tell you that, yeah, my skin itches, there's a burn, it's hot, it's cold, it's sore, it's tight, it's puffy. You know where it is in the body. Somatic pain usually occurs with internal structures, usually looking primarily at musculoskeletal. And so you're looking at muscles and bones. Somatic pain tends to be very focused, very localized. Someone wrenches their elbow, they know right where the pain is. Someone, hits their shoulder, they know right when it happens, right where it is. That's somatic. Visceral, on the other hand, that's an internal pain that is usually more diffuse, and it's usually somewhere within the torso. And so you're looking at something that's poorly localized. And so, doc, my gut hurts. Where? Here, kind of thing. And so they're trying to figure out, are we talking about left upper quadrant, left lower quadrant? And so we have to do a lot of palpation, we have to do a lot of inspection, other type of assessments. Neuropathic pain can result from something causing nerves to malfunction. Nerves can send inappropriate information. They can be sending you too much information, saying something hurts, or they could be going blank and causing deficit. You become numb. People who suffer long-term diabetes mellitus develop what's called diabetic neuropathy. And that's where the peripheral sensory neurons in their hands and feet break down and shut down. And so they become numb. They can't tell when they're developing ulcers underneath their foot. They keep walking on and making it worse and worse and worse. So something is causing the nerves themselves to malfunction, either sending too much pain information to the brain or not enough. Referred pain refers to perceiving pain from the wrong location. With referred pain, I'm going to jump past this screen for a second. With referred pain, what we're seeing here is you have, for example, a patient who is suffering a heart attack. The pain fibers wrapping around the pericardial sac are noticing that there's a lack of oxygen. They're sending information into a spinal root, up to the cord, up to the brain, saying, owie, 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 owie. Well, it turns out that the pain receptors from this part of my left upper limb travel in through the same spinal root. And so if I've got these nerves from my limb and these nerves from my heart going into the same spinal root, and these guys are screaming, owie, 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 all that sodium potassium may bump over here and cause him to start spasm. And now your patient is perceiving pain in this limb when there is no trauma. There is no lack of oxygen. It's not supposed to feel numb, but they perceive that. Back pain could be due to musculoskeletal issue, or it could be due to a kidney stone. And so the power of referred pain is if you're aware of it and your patient comes in and says, I can't catch my breath, my arm is numb. I'm going to throw my EKG. On the other hand, it could distract you where, oh, my arm hurts, and you start checking musculoskeletal, and you're not paying attention to the fact that, how's your chest feel? all kind of type. Really, so referred pain can be useful if you catch it correctly, or it can be distracting if you don't. But understand the mechanism. Now, I want to go back here and talk about the physiology of pain. I want to talk about tonic pain versus phasic pain. Tonic pain is diffuse and chronic. This is the throbbing sensation after slamming your finger in a door. This is a sunburn. This is a headache. Phasic pain is localized and acute. She put her hand on the lid here and it burns, and that sends a signal right to the brain, immediately telling you what happened. Imagine if she had poured some chemicals on the arm here, not causing a burn, but causing itching irritation. And so she's got this throbbing sensation on the arm. As soon as she grabs that pot, the phasic pain is going to override the tonic pain. And so very quickly, any of the little insect bites, any of the chemical exposure, her brain will no longer notice this, because now suddenly the phasic pain from that immediate burn gets priority straight up here. And that's a smart mechanism for your brain to say, I've got to prioritize what's important. Is it the low level constant, or is the, oh my God? I want to send the, oh my God. And so that's where that phasic pain pops in. This is actually why you notice that when you stub your toe, you rub it. Because the stubbing, throbbing is tonic pain, but when you rub it, you're stimulating the phasic receptors. You no longer perceive that throbbing pain. We teach little kids that, when they get chicken pox, don't scratch it, because scratching it is going to cause more trauma, more phasic pain. Instead, do a light little tap. If you do a light little tap, then that's going to stimulate some phasic receptors without causing more trauma, more pain, and that will cause you to that'll cause the brain to deprioritize and ignore the tonic pain. It won't bother you as much. All right, we end up with assessment. We're figuring out some way to be able to quantify. One of the most common techniques, and there's several, but the most common one I come across is the OPQRST assessment scheme. And so this is where we figure out, when someone says it hurts, we want to figure out, what caused the pain to begin? What was the onset of pain? Provocation, did you, were you doing something that caused the pain to occur? The quality of the pain, was it sharp? Is it acute? Is it diffuse? Is it throbbing? The region, where in the body does it hurt? Is it spreading? Severity pain on a scale of, of 1 to 10 kind of thing. And time. Have you had this kind of pain before? How long has it been going on? So asking these questions of your patient allows you to get a lot of good quantifiable information that helps you to be able to diagnose what's going on. Now, the severity part, that's kind of tricky as far as saying on a scale of 1 to 10. And so they have all sorts of scales like this. I love the fact that a few years ago I read a study that said actually the scale is actually fairly accurate. In terms of, if a patient tells you that it's somewhere between a 4, 5, and a 6, that doesn't matter whether that person is a wuss or is a real macho individual and they don't let pain bother them. The same trauma in either individual will usually be reported as a 4, 5, or a 6. So if your patient can't decide whether it's a 4 or 5, who cares? If they're in the middle range, that tells you there's a moderate amount of trauma. 1, 2, and 3 falls into the same window. 7, 8, 9 falls in the same window. And so actually it turns out that the numeric scale is actually fairly accurate and fairly reproducible. Now, if your patient cannot respond to numbers, say it's someone who has a different language, or if it's a child who can't communicate verbally well with you, you can use little emojis. And these can help you to help them, help you understand the severity of the pain itself. And there's all sorts of different emojis for all sorts of things that can help you identify all sorts of this and that and this and that. But that's the short little video right there talking about pain. I wanted to talk about some of the major details in terms of the different types of pain, talk about the physiology of tonic versus phasic, and I wanted to talk about referred pain and finally pain assessment. So read through the end of the chapter, make sure you understand it, look through my outlines, let me know if you have any questions. Good luck.